So, my name is Ajani Benjamin. This is Jose Sanchez. We're going to start in one moment. But before we begin, I actually have a question for you guys. Folks come to sessions and they have questions for us. No. We're going to flip it around. Questions for you. I'm always very curious about who our audience is, and it helps us kind of tailor our message to who's in the room. So just by show of hands, how many folks are on the advocacy side of harm reduction? Okay. Well, hopefully all of us sometimes, right? Who are, we have mental health practitioners? Lots of folks. Okay, I suspected as much, given the first two presentations. Folks doing on the more syringe exchange, HIV prevention. Okay, all right. So I am going to sit in a moment, and Jose is going to take on the bulk of this presentation, really looking at buprenorphine and really looking at the use of buprenorphine as part of the spectrum of harm reduction or abstinence, or opiate replacement therapy, if you will, is used as part of the work that we do. And so Jose will take it from there, and I'll be over here in the peanut gallery. So this one, you'll figure it out. It's good times.
So how's everybody doing?
Good.
It's funny. All day last night and today, I was saying to Ajani and to coworkers, I need something funny to say, and I didn't have it. I didn't have it until this very moment. It's funny, we were supposed to go first, I think, in this presentation, and because we wanted our coworkers, that's Sadat and Teresay and the gentleman in the back, we wanted them to be present at this presentation, allowed the other two presenters to go before us. Well, that's a hell of an act to follow. But you know what? We're from New York. And if it ain't rough, it ain't right. So that's it. That's as funny as it gets. With that being said, my name is Jose Sanchez. This is Ajani Benjamin. We work at the Lower East Side Harm Reduction Center. I have been in charge of the buprenorphine program since about 2008. Currently, we carry 55 active Suboxone clients, and that fluctuates month to month, depending on what it is that they want, and we give them what they want.
The last one.
Okay, so you see?
Yep.
That's funny too. Okay, so what we're covering today? Opiates, opiate dependence, how buprenorphine works in the brain, obtaining a script, life with you, and other services at the Lower East Side. Oh, that's cool. So, opiates are drugs that are derived from opium, while opiates refer to the entire family of drugs, fully or partially synthetic, that mimic the effect of the body's natural painkillers. Opiate dependence. When an opiate binds to the opiate receptors, the brain creates the opiate effect, which in the beginning of opiate misuse may cause a person to get high. Over time, opiate receptors in the brain become dependent on the presence of opiates, and when there are none, the person experiences symptoms of withdrawal. And this is what, this is what it used to look like, it's the pill. Now we're moving to the film for so many reasons. One reason is, I think, accountability. As the film comes in a quote-unquote child-proof little packet, and the pill doesn't. AKA Suboxone or Subutex. Can anyone tell me the difference? Yes?
Suboxone has naloxone with it.
Very good. And who can receive Subutex today? Pregnant women. Thank you. Wow. I'm gonna have to see in a minute. Okay. So these are some of the benefits of you. They're administered by the patient they're not necessarily connected to a program that mandates attendance, and they're available at many pharmacies. In fact, I think if a pharmacy doesn't have Suboxone, they're shortly going to be out of business. I'm not going to get into the dots and the eyes and stuff like that. I'm just going to go ahead and crash through this. This is what it looks like in the brain, right? This is once they're satisfied with opiate, the strong opiate effect from the painkillers or heroin stops the withdrawal symptoms for a short time. The person is high. After prolonged use, the patient is no longer getting high so much as just preventing the withdrawal symptoms. Opiates replace and block by buprenorphine. Opiates cannot get to the neuroreceptor while occupied by buprenorphine. The person no longer feels sick and is unable to get high even if she uses other opiates. Buprenorphine produces a limited opiate effect and cravings are reduced or eliminated. And this is something I talk to my clients once they start the Suboxone. If they go ahead and start the Suboxone and decide to go get high and go spend $20 or $30 on some heroin, I say, give me a call. You're throwing away your money. That was supposed to be funny. So, over time, buprenorphine dissipates and still creates a small opiate effect and still blocks opiates from attaching to the receptors. This means if someone were to take an opiate, they will still not get high. These are some of the prerequisites, not just with us, but in a lot of places. A physical exam in the last days, and the reason for that, if there's any liver damage, the doctor needs to know where the liver's at because some of the side effects that buprenorphine can cause to the liver. Medical insurance, not necessarily to see us, however, to fill the script, because something that Ajani will talk about later is that all our services at the Lower East Side today are free. However, you will need the Medicaid or insurance to get it filled. Excuse me. The ability to meet with the bupe provider on a regular basis, you have to be between 30 and 40 milligrams or actively using opiates. Ideally, 30 or 40 is a good number. So this is how the induction works. Person comes in, they're mild to moderate withdrawal. We discuss appointments and latenesses. We talk about the medical history and psychiatric history. And at times, the doctor will directly observe them taking their first dosage. Some of the risk. Alcohol, benzos, pregnancies, and medical allergens. And this picture is an arbitrary, it's a black man, yes, but he's working. And it's to bring home the point of life. What happens with buprenorphine? What happens? The ability to return to the workforce. There's discretion and privacy. It's, you take your script to the doctor, to the pharmacy, you drop it off, nobody's in your business, you walk away and you have your prescription. You're able to travel, go on vacation. Teresa helped us out with that this morning. You know, you're able to go. You're not tied to the methadone program on a daily basis. There's reduction in drug-seeking behavior. There's an overall change in lifestyle, and there's an overall improved quality of life. And that's it. That's in a nutshell, Suboxone. One thing I wanted to add that at our agency, it's a small agency. Tatarsky, you've been there. It's the doctor and it's me. We're not set up for emergencies. Hurricane Sandy was devastating, and we're still playing catch up. However, we do a hell of a job, and I'm quite proud of it. Yes. Questions?
I'm just going to, before we have questions in a second, I'm just going to talk about our other services.
Right.
One of the things that I think Jose is being modest in terms of mentioning is that our Suboxone program is one of our most successful. The fact that we've got always about 55 active Suboxone cases, it's what folks, you know, they get my extension by mistake and they're always asking, oh, you know, I need to get Suboxone. Folks who are making this decision right? There's this intentionality where they want to change their use, or they want to end their use, and they want to use Suboxone to do it. And so we often find ourselves in a situation where we need to make referrals out because our prescribing physician is at a maximum in terms of the number of patients that he can see. But Suboxone does not happen in a vacuum. I think one of the things that's important to mention is the fact that folks come to the conclusion or to the decision around changing or altering their use because of the other services that they encounter. Our first service is syringe exchange. We will always do syringe exchange. It is at the very heart of our agency. But I think what happened over time, 20 years ago when we began, was that syringe exchange was not enough. Folks needed more than just needles. When we have interns, one of the things that I often tell them is that a vending machine could give out syringes. And that this panel talking about changing the relationship is really what it's about. It's about changing that relationship between our participants and, as Mr. Kellogg would say, the drug, and their relationship with us. Because it's in that relationship that those decisions get made. And so one of our second services was case management. There was a notion that active drug users couldn't get mental health services. A lot of models suggest that the person end their drug use first and then seek therapy. And we realized that folks are more than just their drug use. And that if we begin to address some of the underlying reasons for drug use, the decision to change use may come on its own and can be supported through case management and through some of our support groups, the substance use services that Jose provides. We also realize that housing is an immensely important part of harm reduction in the person's ability to stay safe, to have some place where they can use without having to duck and cover, looking out for the police officer who may be coming up behind them. And so housing is one of our services. Peer education, the notion that a lot of individuals will come in as a participant and leave as an intern, as an outreach worker, as someone who wants to give back. And so our outreach program and our peer education program that Sadat coordinates makes a really, really important difference. We're just beginning to look into youth services with our definition of youth being 18 through 29. And again, it's understanding that lots of other agencies that focus more on young people have cutoffs. So the agency that's only a few blocks away, their age cutoff is 24. Well, what does someone do when they've reached that age? But a lot of the same issues are still there, and they still need a safe place to address some of those issues. We have Narcan and opiate overdose prevention, of course referrals, holistic services including Reiki, yoga, and acupuncture that we provide about 4 times a week at our facility, which is open 6 days a week. There was another one I wanted to mention, and it's suddenly gone. It clearly left the room. But I think at this point you want to open it up for questions and get feedback from you.
This is great. I'm learning a bunch from this. I'm seeing benefits, but you also briefly mentioned the risks as far as I'm guessing if you mix alcohol or benzos or whatever with Suboxone, what does that come out looking like?
So Suboxone is designed to have a ceiling effect. Where at 32 milligrams, it's really not going to have as much an effect anymore. That's the highest dose that someone's going to be on. And because of the Narcan that's in Suboxone as opposed to Subutex, which does not have it, the person is unlikely to be able to get high while they're on it. The way that they can kind of break that protection is by adding another depressant, such as alcohol, or adding benzos, where the person may be able to get high or may risk an overdose. And so these are some of the things that during induction, Jose or our doctor will share with the person to kind of give them this heads up that the goal is for the person not to try and use Suboxone to get high. It's a lot easier for them to buy a bag if that's what they want to do, but that this has some other risks attached to it.
I know in the past the cost of the medication was prohibitively expensive. Is it still, and is it still only distributed by one drug company?
No.
It's covered by most insurances, so it's just the co-payment. Even paying out of pocket, I've heard some folks say it's a couple of dollars, $6 or $7 per dose.
Okay.
So it's not, if you compare $6 or $7 compared to $30 or $40 daily, it's cost effective.
And like also generic now.
Yeah.
Oh, okay.
So Subutex is generic. Buprenorphine is is generic, and Suboxone is on its way to being generic. However, there's some controversy because Reckitt, which produces Suboxone, has moved to say, oh, it can't be in pill form because it's not child-proof. You have to use the film, which they have a longer patent on. So.
Which I'll tell you, and if it leaves the room, I will completely deny. It's a bunch of bullcrap because the pills themselves. I mean, I could take one now and just chomp on it. It's not going to work. It's a sublingual tab, which means I have to know to put it under my tongue. And a child who might be rifling through their parents' stash of Suboxone isn't going to know that. They're going to eat it like candy. All right. One of the other, you mentioned risks earlier on, one of the other things that's important to discuss during induction is that Suboxone isn't to be administered when a person is not in withdrawal, right? Which when a Suboxone program is being set up, that's really, really key and really important. I worked at another agency, I'm not going to mention which one, and their psychiatrist had very, very strict rules around attendance and appointments, and even the physical was just very, very stringent. And so I made a referral to him, but even in making the referral, I was afraid. And so, being the harm reductionist that I am, this was not necessarily a harm reduction agency, I said, listen, here's what you're gonna do. You're gonna buy a bag and you keep it in your purse. If you miss the appointment, if things go awry, if that psychiatrist is not gonna write you that script, you go in the bathroom, you do what you gotta do. Because the first part of the message was you need to go to that appointment in withdrawal. What we see, because Suboxone has a street value, is folks self-inducing, and if they're not in withdrawal, they're going to have precipitated withdrawal, which is going to hurt like hell. You know, and we try and explain that to the person. You know, I don't know any user that's never experienced withdrawal, but if you want to feel worse, you go ahead and you take Suboxone while you're fine. It's gonna come like a ton of bricks, and those kinds of messages are important to kind of let the person know what they're getting into, and to give them the full range of options so that they can make an active choice.
Do you require that they attend any services while they're doing Suboxone at your center?
They have to meet with me at least once a month, and we do random urine tests, and certainly not punitive, but of course if they don't meet with me, they'll definitely not meet with the doctor. That's the only requisite that we have once they're inducted.
Other programs, like methadone programs who've begun to kind of use Suboxone will attach Suboxone to the other programs that the person has to be engaged with. And rather than giving the person their own script and saying, take care, they will give them one pill at a time. Gross, certainly not harm reduction in any form, right?
So I work for a hospital that's like that, but in the office-based clinic, no, I mean, and it's one that relates to my question. Other requirements to do kind of an office-based model would be like stable housing and being psychiatrically stable, and there's like a whole list of things that like 90% of people can't meet. When I looked at your list, there's nothing, you know.
What do you say?
Low threshold.
Very
yeah,
low
and I'm
threshold.
wondering what
Low
kind of
threshold.
outcomes you're getting with
Well,
that.
when we talk about, we're getting prepared for an audit now, and folks fluctuate between active Suboxone and inactive. In the inactive, it's about 100 cases now that we have to go through. What we never want to tell someone no, you know, easily. If the person came back tomorrow and said, I need Suboxone, it's a process, you know, but it's certainly a shorter process than at the very beginning, doing an intake and stuff like that, but we never would turn anybody away.
Sheila?
Can you talk a little bit about going from heroin to Suboxone versus from methadone to Suboxone?
Okay, and again, in that other agency whose name I won't mention, I've seen that, and I was in the role of a prevention case manager, and so my job was to literally escort the person to the pharmacy and then kind of be with them while they self-induced. They were not on methadone, and their habit was closer to 3 bags a day. And so on the train ride, we're on the F train, heading back to the agency, and I actually saw this change. It was back when it was only in pill form. He broke it in half. It came in 2 milligram and 8 milligram. And he got the 8 milligram, he snapped it in half, and he took the first one. And we kind of almost got into something because he snatched a candy bar, Dwayne Reed. But I talked us out of it, and we get on the train, and he was feeling horrible. Really didn't want to be there. Felt like crap. Before we got back to Queens, which is where the agency was, I saw a difference. And by the time we got back to the agency and took the other half, it was the regular him. and this was someone who was, you know, not on methadone. This was an induction from heroin. What has to happen is the person has to be in withdrawal, and that's more difficult when someone's on a higher level of methadone, which is why, I mean, I've heard it as high as 50 milligrams,
You can go.
but certainly no higher than that, because the period until the person gets to withdrawal is just, you know, it takes forever. I mean, that methadone lasts.
Has Bupe been used with other opioids like Oxycontin or something, you know, the artificial opiates?
It's not recommended.
No.
Because if you're using opiates like Oxy for pain management, they don't
But what if it's no longer?
Just for clarity, are you asking about a transition?
Yeah.
Okay, so you're asking about, so if someone
is addicted to say Oxycontin and is not using it for pain management any longer,
yeah.
could they be put on? Would you help them?
I have several clients that came from abusing Oxy after having an injury or surgery, and now they're on the Suboxone successfully.
Just to follow up on the difference between the Subutex and the Suboxone. Subutex now is generic form, and it's you sentence a tablet. And I noticed that the only people who are eligible are pregnant women. I mean, if everybody was still eligible for Subutex, surely you could do many more people.
Right.
Yeah, that's true. I mean, the reason why is that because there's naloxone and the Suboxone, and you know, of course, push you in withdrawal. But it's not necessarily. There's no like legislation or something that makes it that way. It's insurance reimbursement and Medicaid, American.
To follow up on that, in the time I've run the program, we've had one pregnant female, and we followed her with Subutex while she was pregnant. But now her baby's what, 2?
Yeah.
And now she's back on regular Suboxone film, but during her pregnancy she was on Subutex, and that was the only one that I know of.
How long are your clients on Suboxone?
That's a great question. At induction, it's not something that we talk about. However, if some folks will come in with a plan and say, listen, I just want to be on this for 6 months, and that's okay. But if after 6 months they're still not where they're at, we'll continue to see them, absolutely. But we don't want to set that high of a goal, because if we're talking about taking away 20 years of addiction in 6 months and then you fail, the fall is quite devastating. So if a client comes in and says, listen, and I have one in my mind, I just want to be on in 6 months, guess what? It's been a year and a half now, and it's okay.
Do they periodically step down?
They have their slips. Yeah, they have the slips, and that's when they move into the inactive caseload. And then when they come back, they get pulled into the active cabinet.
And some facilities exclusively use Suboxone as a way to detox from other opiates. I know of another facility that differs from ours in the sense that the person, here we have cases and we kind of follow the person. There's another program where the psychiatrist prescribes it, not on an ongoing basis, but as a way for someone to take a vacation from their heroin use.